Hey everybody, welcome to BFR Tuesday. I'm your host, Ed Cara, and I'm here in my clinic in Dallas, Texas, Body Lounge Park Cities. And today we have a new study that just came out, and it's on BFR and ACL reconstruction. So I thought this might be of some interest. And so we're gonna go through that study, kind of dissect it a little bit, and then I'll answer any questions and we'll go from there. So it's 12:59. I'm gonna wait just 1 minute and we will switch over. If you have any questions for me right now, please send it into your, just send it as a message. I have uploaded this Hughes 2019 study for your access and your reading enjoyment. All right, 1 o'clock. Any questions? Quick 15-second. Got any questions about BFR, anything, please let me know. Otherwise, I'm gonna switch over to sharing my screen. All right, I'm gonna share my screen. Okay, so here we go. All right, I'm gonna just click on my highlighter. All right, so comparing the effectiveness of blood flow restriction and traditional heavy load resistance training on the post-surgical rehabilitation of ACL. This was a UK National Health Services randomized controlled study or trial, RCTs. Dr. Hughes was the original author. So 8-week rehabilitation program in an ACL patient. They wanted to compare the effectiveness of blood flow restriction training, BFR, and standard care traditional heavy load resistance training at improving skeletal muscle hypertrophy and strength, physical function, pain, and effusion in ACL-R patients following surgery. So 28 patients scheduled for unilateral ACL-R with hamstring autograft recruited for this group. Following surgery, a criteria-driven approach to rehab was utilized and participants were block randomized to either the high load at 70% repetition max or BFR at 30% 1 rep max. So we'll keep in mind that 30% 1 rep max here is what was used. If you're new to this or to BFR, we typically train somewhere between 20 and 30% 1 rep max. They completed 8 weeks of bi-weekly unilateral leg press training on both limbs, totaling 16 sessions alongside standard hospital rehab. Resistance exercise protocols were designed consistent with standard recommended protocols for each type of exercise. They did a resistance exercise or a 10 rep max strength test, muscle morphology of vastus lateralis, and self-reported function, Y balance test performance, knee joint pain, effusion, range of motion. So I don't like this when 4 participants are lost, but it is what it is. 24 participants completed the study, 12 per group. So it looks like they had dropout 2 of each, so it's not too bad. No adverse events or differences. All right, so let's get down to the methods. Well, if you want to cut to the chase, what they found was the BFR improved skeletal muscle hypertrophy and strength to a similar extent to high intensity with a greater reduction in knee joint pain and effusion, leading to greater overall improvements in physical function. Therefore, BFR may be more appropriate for early rehab. So again, high load, you're gonna find similar results with BFR, but I think this is interesting because what they're really looking at is outcomes from a functional standpoint. And there's not many studies that have looked at function with strength and hypertrophy. So I think this is pretty cool and pretty novel. I'm not going to just go through and read all this, but let's look at the methodology, which is of some interest to me. You can look here at what they excluded, which was multiple ligament ruptures or trauma, RA, other significant comorbidities, history of deep vein thrombosis or vascular pathology in any limb, anticoagulant medications. Okay, that's about it. Okay, 8 weeks of unilateral leg press training twice per week. Okay, so total of 16 sessions. Well, remember that 2 to 3 times a week has been shown to be as effective as 5 times a week, comparing BFR. So 2 times a week is totally appropriate and is enough. Appears to be enough dose. It's what I use in the clinic quite a bit, twice a week. 5 minutes of unloaded cycling, 10 repetitions of unilateral leg press at a self-selected weight, subsequent 5-minute rest. They predicted 1 rep max in order to get from their 10 rep max, which is what we teach. And let's see, anything else interesting in here? Ooh, I like this, where the training load was increased by 10% if participants completed all repetitions on 2 subsequent sessions and was formally readjusted after the mid-training testing. What you'll notice when you're using BFR and they've never used it before is after about 3 sessions, you'll start to increase load. People will start to get used to the cuffs and that hypoxic environment, and so you can start to load them a little bit more. I typically don't mess around with pressures. Pressures remain as consistent as possible so that I have less confounders to my training protocol. Let's see, what else is interesting out of here? Okay, so they used a Delphi. So what that means is that they used a limb occlusion pressure. And let's see what they used. 80% limb occlusion pressure in the lower extremity, which is what we teach as well. So this would be very similar. Muscle morphology, they did this as I did my study, looking at lean mass versus fat mass in the tissue. So this is very cool. They used the ultrasound measure of that. And all right, physical function, International Knee Documentation Committee Subjective Knee Form. What else do they do? Arthritis function. This all looks pretty normal. All right, nothing too crazy. While the participants lying supine, a fusion was evaluated by measuring the mid-patella knee joint circumference and going to a 0.1 centimeter using flexible tape measure. Remember, one of the contraindications is excessive swelling. I usually use a larger than 2 inches more circumferential measurement on one limb compared to the good limb. So it's interesting that they measured a fusion to see if it changed and it improved. Knee joint laxity was measured and quantified, which is super interesting. I'm not familiar with that unit, the ligament arthrometer. So that's kind of cool. I'd like to look into that and see what's up. Also, knee pain scale. 0 to 100 is what they used. They looked at range of motion, all things that are measuring really performance and outcome. All right. So average age, 29 plus or minus 7 years. Gender, male to female, 7 to 5, 10 to 2. Okay, so lots more males than females in this study. Date from surgery to post-surgery testing. So 7, 4. Okay, 7 days and 4 days. Okay. Limb occlusion pressures, 186, non-injured 196, interesting. Okay. Let's look and see what else we have here. All right, you can read through all this. Let's jump down to results section. So the first one, this is the first study with ACL-R looking at strength, hypertrophy, physical function, and knee pain. You had similar increases both with BFR and high load. So what they're saying is BFR and high load are equally effective at improving muscle mass. 6 to 8% increase over 5 to 12 weeks of training. All right, let's go down. Here's what's really interesting to me is the physical function. So greater reduction in pain with BFR. And saying it might respond to or might contribute to an anti-nociceptive response, which is what we find in the clinic a lot. Progressive limb loading phase of rehabilitation advantages of BFR over high load are that it can be used to allow a greater reduction in pain and infusion and improve physical function to a superior extent compared to high intensity, with no detrimental effect on muscle hypertrophy and strength improvements. So we can use the lighter loads, it looks like, still get that strength and hypertrophy as compared to doing high intensity training. So I'm going to let you all kind of read through this, but this is a good study looking and kind of contributing to the research around specific conditions, which is what we're starting to see more and more about specific conditions. I think it's interesting about looking at outcomes. So important, like who cares if we get increased strength and hypertrophy if our outcomes aren't any better? So overall, nice study. So hopefully you can download that if you are treating ACL patients right now. You can take some of that information, but it also references some of the other ACL BFR studies, and you can utilize some of the content in there to try to improve your outcomes using BFR. I have found post-surgically game changer, getting muscle units firing and recruited very, very quickly. And much faster to normal return and back to high intensity loads. Any questions regarding this huge study or anything else regarding BFR or any thoughts, comments as you went through? All right, well, I appreciate your attendance today. I don't know what I'm going to talk about next week, but I will start to try to announce this stuff a little earlier. I just stumbled upon this study, and I thought it would be of relevance for a majority of the people on this podcast. So hopefully that helps, keeping you abreast of current BFR literature. If there's anything I can do, please let me know. You can always reach out to me. I am ed@edlacara.com. And if some of these protocols and things you're not sure regarding, I got a question. Elaborate on contraindications, specifically varicosities. So varicosities are not a contraindication, not an absolute contraindication, but it is an indication that there's poor circulation. So I'm going to take that into account with other factors of poor circulation. I'm going to look at capillary refill time. I'm going to look at any previous thrombosis. I'm going to look at stasis. I'm going to look at other things that may contribute to a risk of thrombosis. But varicosities are not standalone. It's just a sign that there is a little bit of impaired circulation in the lower limb. I have varicosities. I've had some of them removed. I still use BFR on my lower extremities. It can become a little achy if I do it too many times, back to back to back, like 3 days in a row, let's say, if I'm traveling. But that's the only real problem with it is they can become a little bit sore. But other than that, you're only really occluding for 15 minutes with an aerobic capacity training up to 20 minutes. And then when you're doing exercise, it's only for 6 minutes really when you look at the 30, 15, 15, 15 protocol. So again, varicosities are not an absolute contraindication, just a relative, and it makes me just look a little bit tighter and make sure there's nothing else going on that would be compromising of the vascular system. Any other questions? You're welcome. All right, y'all, thank you so much. Download that, take a read, and let me know if there's any questions. Otherwise, I will see you next week. And if there's anything I can do to help you with your BFR journey or anything else for that matter, please let me know. Thanks.